Okay, fine with everyone? Any
Yes,
confusion?
ma'am.
Yes, ma'am.
Okay. Next, I think Dr. Zarina, you told.
Yes, ma'am. Yes, ma'am.
Here is your question.
A 23-year-old woman with ulcerative colitis treated with anti-TNF alpha drug infliximab attends for preconception counseling. What advice would you give regarding infliximab and pregnancy?
Hmm. Infliximab is which category drug?
Monoclonal antibody.
It is
Biologic.
biological. It's biologics, and by 16 weeks it should be stopped. What I think is because then, when the later on the it would result in my baby's immune system, and the
Hmm.
baby would not have the vaccination and all these things.
Okay, fine with everyone? Anybody has any other option? Okay, so correct. This is H is the correct answer, 16 weeks. But it is important to remember that not all of these drugs need to be stopped at 16 weeks. Okay, it depends on the half-life. So the drugs which are longest half-life, they for this particularly infliximab, it is considered to be stopped at 16 weeks, while the etanercept and the adalimumab, they can be discontinued by the third trimester, right? So 16 weeks is the correct answer here. Now, 32-year-old, oh, sorry, who is going to take this? Easy question. Come on. Nobody wants to do? Again, Dr. Surya, okay. You can do if nobody is doing.
32-year-old woman attends for postnatal review 8 weeks after cesarean section at 30 weeks of gestation following an eclamptic fit. She has been off antihypertensive therapy for 6 weeks. Her BP is 120/64 millimeters of mercury and BMI is 23. Choose the contraceptive option that should not be used. She is now post C-section 8 weeks following an eclamptic fit. And now the BP is normal, of normal BMI. So choose the contraception which should not be used.
All options can be used.
Ma'am, by once she crossed 8 weeks, we can even use copper IUD. Everything all can be used. So all options may be used.
Fine. So, which is the correct answer? Option?
L.
Right? So, everyone okay with this?
Yes, ma'am.
Yes, correct. Here we can use all the options, right? So, since now the hypertension is controlled and there are no other risk factors. She is 8 weeks, BMI is normal, blood pressure is controlled. So, all of these can be used. So, basically, history of high BP during pregnancy, everything is 1. There is no contraindication. Okay, next question. Next question, who wants to take? Try. That's fine. Yes. Dr. Nidhi, yes. Okay.
55-year-old woman who smokes 15 to 20 cigarettes per day had THPSO because of a 10 centimeter ovarian cyst. 48 hours later, she complains of feeling increasingly unwell, temperature 37.9, pulse 121, BP 127 by 92, respiratory rate 27, saturation 95. So complication, smoker.
Chest infection. Chest infection. C.
Simply feeling unwell.
Yes, ma'am. Chest.
Having tachycardia with chest infection.
Chest infection. That's the correct answer. So what are the options? What are the key words in favor of that?
One, she is a
Smoker.
and this is present. 48 hours later, there is temperature and tachycardia. He's feeling
Ma'am,
unwell. There is
unwell is something which is pointing to infection, and temperature is borderlinely raised. And then pulse is not that which is telling about embolism or something. It is mild tachycardia, and mainly the temperature and the word unwell and the tachycardia.
And duration 48 hours after
And
the
48 hours.
So basically this is not embolism because one is that is usually sudden onset breathlessness. Here the patient is increasingly unwell and as such she is tachypneic but not mentioned anything like chest pain, severe or sudden onset breathlessness. Such words are not mentioned here. And so overall this is not a scenario of pulmonary embolism. This is a scenario of chest infection. And temperature is also slightly higher side, right? So this is a scenario of chest infection. Fine.
Ma'am,
Yes.
ma'am, if they would have given like any symptoms of like tachycardia, tachypnea, or shortness of breath, then fallen SpO2, then it goes favor of pulmonary embolism.
Pulmonary embolism, but that is a sudden onset thing, not
Sudden.
gradually coming up.
Ma'am, will it present on the day 2 or day 3 or still late, ma'am?
It can present.
Embolism, it can present on day 2, day 3. Yes.
Okay.
Okay, fine. Everybody okay?
Yes, ma'am.
yes, ma'am.
Next question. Dr. Lavanya, okay. No new person wants to try. Okay, Dr. Lavanya, yes. Here is it.
A healthy 27-year-old woman had a category 1 cesarean section because of fetal bradycardia. She had rectal diclofenac and IV paracetamol at the end of the procedure. 3 hours after the operation, she complains of severe pain. Clinical examination is normal. So here, diclofenac, paracetamol was given IV.
What next?
Second line can be dihydrocodone.
Post cesarean.
Morphine.
Morphine
Ma'am,
can
you
be.
discussed this.
3 hours after the operation.
G.
Okay.
IM diamorphine 3 hours after the surgery. So
Yes,
can
that's
with
the
G.
correct.
G
3
answer.
hours after the operation,
surgery.
so we have to choose the parenteral morphine and IM is the first choice. So IM dimorphine is the correct. So how do we go onto the ladder? Rectal diclofenac, IV paracetamol, that is paracetamol and non-steroidal anti-inflammatory. Then we move on to the morphine. In morphine, usually it is oral first, but this is only 3 hours after the surgery. So we have to start from the parenteral. Else, if the patient is vomiting, then also we start with the parenteral. So IM dimorphine is correct answer.
Ma'am, after how many hours can we start with oral?
No, it is
Once the bowel
But ma'am, we discussed as like a parental.
just 1 minute. So basically there is no fixed thing, but as soon as patient feels comfortable to eat or drink, then she can start the oral, which is usually like between 4 to 6 hours,
Yes.
right?
Ideal analgesic post cesarean first is paracetamol and diclo, and then it is morphine IM, ma'am. I mean, ma'am,
Morphine, oral or parenteral. Like if this patient is in 6 hours, then we will choose oral morphine.
okay, ma'am. Okay, ma'am.
Okay,
Yes, ma'am.
fine. So Dr. Nisha, can you please repeat what I have repeated? Yes.
Ma'am, can you please again repeat this ladder? First one.
Paracetamol and the non-steroidal anti-inflammatory drugs, right?
Yes,
After
ma'am.
that comes the morphine. Morphine first is to give the oral. If there is vomiting, then we can give the parenteral. In parenteral, IM first and then IV.
Okay, ma'am.
Ma'am, then why not oral morphine here, ma'am?
3
3
hours
from the
post
operation.
surgery. 3 hours.
And patient has severe pain, so that's it.
I
3
am. Okay.
Ma'am, but it's diamorphine here.
Yes, morphine and diamorphine is largely used as compared to original like morphine.
Isomosmate. Okay.
Ma'am,
Ma'am, when do we use codadamol and dihydrocodone?
Dihydrocodone either we can use in the antenatal period if it is moderate pain, not mild. Mild we will use only paracetamol, but after that we can use dihydrocodone for the moderate pains, but not in the labor, right? Not in the labor. And later on in the patients, after this post-op, immediate post-op period, you can use that.
Okay.
But it is for the moderate pain. Not like milder pains with the paracetamol, ibuprofen, moderate for the dihydrocodone, and moderate to severe for morphine, dimorphine.
Okay, ma'am.
Yes, ma'am.
But here it's written severe pain.
So that is
That
why
is-
we are going for the morphines, no?
Yes, ma'am.
Right.
Ma'am, severity of the pain will also help us decide the route of the drug. For example, if it is in severe pain, then
IM or IV?
maybe if we say that she's 6 hours post and she's having severe pain, then will this route be changed into oral or IM because of the severity?
No, oral can be given for oral is also a recommendation is same. That is moderate to severe. The recommendation is according to drug, not the route. The severity does not define the route of administration.
So we'll start with oral and then
Then
parenteral.
we go on to the parenteral route, particularly if the patient is vomiting. Sequence of, sorry, yes, yeah.
Ma'am, just to potentiate one more thing, that generally when the lady delivers normally, then we are giving her rectal diclofenac. So in post-cesarean also we are giving rectal diclofenac if we are not able to give her orally in the first few hours after surgery.
No, largely it is paracetamol, IV paracetamol, and rectal diclofenac can be used, not as a regular thing, but it can be used because it is only one dosage which can be used, right? So if
Yes,
that is also not effective, then we can move on to the morphine.
Okay, ma'am, if there was an option of IM morphine as well, what would you have chosen? IM morphine or the IM diamorphine for this sort of severe pain after cesarean?
Morphine.
Okay, thank you.
Ma'am, it's
okay, so actually there's a question in the chat box, so I was answering that.
okay, ma'am.
Okay, so the sequence of drugs is you use the paracetamol and the non-steroidal anti-inflammatory drugs, because you cannot give oral non-steroidal anti-inflammatory drugs. So rectal diclofenac is one of, only one of those can be given. If they are not working, then we move on to the morphine. Morphine oral, IM, then IV. If the patient is vomiting, we will go for the parenteral. Intrathecal is given if the patient is already in the epidural analgesia. Then it is patient control analgesia.
Ma'am, they'll mention ki like the patient is under like
Yes, of course. If the patient is not having the epidural catheter, then how will you give intrathecal?
No, because like this is cesarean section, so mostly like she must be like it must have been done under spinal or
Spinal will not have epidural analgesia catheter. Spinal and epidural are different.
Yes, ma'am. Like if it would have been done in under like epidural and the catheter is there, they will mention in the question.
Yes.
Okay, ma'am. That only I wanted to know. Thank you, ma'am.
Then the option can be the top-up of epidural, ma'am, or we should go with analgesic protocol only, ma'am.
No, till the catheter is inside, we will top up that intrathecal.
Okay, ma'am. Yes, ma'am.
When to choose dimorphine or dihydrocodone, and if we choose morphine. So dihydrocodone is not for the patients in labor or immediate post-op period, right? It is in the either the antenatal period or in the later period of the recovery. Okay, when patient is discharged or goes home, that, and that is only for the moderate pains. Dimorphine is for moderate to severe pains, dimorphine and morphine. But in particularly after this cesarean section, morphine is the preferred agent. Right?
Ma'am, if the epidural catheter is there and she is having severe pain, would you go for the remifentanil patient control analgesia or the diamorphine intrathecally?
Severe pain will be intrathecal.
Ma'am, which agent are we going to choose then? Remifentanil patient control analgesia, remifentanil or the diamorphine?
See, that depends on what patient is already using. What patient is already using, that needs to be topped up. Na? So you don't mix everything together.
Okay.
Yes, ma'am.
Okay.
Yes, ma'am. Thank you.
Okay. Now this is the next question. Who is going to take?
Ma'am, I'll take up, ma'am.
Yeah, sure.
A 23-year-old woman with type 1 diabetes mellitus attends the antenatal clinic at 36 weeks of gestation. Glycemic control has been good through pregnancy, and estimated fetal weight is on the 60th centile on growth chart, and abdominal circumference is 50th centile, and normal Leica volume. Blood pressure is 125/68, and there is 2+ glycosuria. HbA1c taken a week earlier is 6.3. Okay, ma'am. She's at 36. Ma'am, she's at 36 weeks and HbA1c, and then the sugar control is good only because it's at the borderline HbA1c 6.3, and then we can still prolong the labor, and we can think of induction at a later date, ma'am, and that is why I will go for the option G, ma'am.
Right.
And it doesn't look like it is macrosomic or large for gestation. The baby looks average sized according to the centiles, and there is no other complications because BP is also controlled. So the situation scenario is under control only. So we can plan for induction of labor. We can still give time, ma'am. So I will go for option G.
So G is the correct answer. Absolutely correct. because she is 36 weeks and we can still go ahead for one more week. Glycosyria 2 plus may need the monitoring or modification of the dose, but no admission is required, right? And no
Yes.
other option goes in that value. And first she requires the blood sugar levels and then she will go ahead with the management. So for now, after 1 week, she can go for the induction. So induction of labor at 37 to 38 plus 6 weeks. That's fine. Good. Next. Next question, who is going to take? Nobody?
I'll do, ma'am.
Okay.
A 27-year-old woman attends the antenatal clinic at 20 weeks gestation. She has a history of chronic hypertension and AC inhibitors were changed to labetalol prior to pregnancy. Her renal function is normal and BP is 142/92 with no proteinuria.
What is the scenario? I mean, what's the diagnosis?
She's a chronic hypertension.
She continues
case,
to be
ma'am.
chronic hypertension, ma'am. So
Yeah.
we have to continue
Let her
labetalol.
try. Let her try.
I'll go
Just
with
1 minute.
That is the chronic hypertension. That's
First,
why we are.
1 minute, 1 minute. Let her try, then we'll come to everybody, right? We can discuss, but let her try. Yeah. Yes. Yes,
Ma'am,
Dr.
yes, ma'am. Since she's a case of chronic hypertension, we have to continue her oral labetalol and growth scan plus umbilical artery Doppler every 4 weeks from 28 weeks. So I think H is a good answer.
Fine. So now everybody who was like, whoever wants to comment, yes. Yes.
Ma'am, why not G here? Because
she was changed to
already
labetalol.
she is on labetalol.
Okay.
AIM is 135/85, no, ma'am. So I think that it should be H only.
It was on labetalol, ma'am. But the thing is, first thing, I feel that the labetalol continuation should happen. So that is the only thing which is clinching me to H.
Yes.
And she's
Same,
chronic
ma'am. That is
hypertension.
why I'm choosing H because they
Yeah.
have not mentioned. I mean, that whether she's continuing, not continuing. So since the BP is not reduced, we need to continue her labetalol. That's why I went with H.
So H is the correct answer. Because they have given that that was changed to labetalol prior to pregnancy, but not mentioned whether presently she is on labetalol or not. So that has to be continued. So H is the correct answer. Perfect. Good.
Thank
you.
you.
Oral labetalol plus growth scan plus umbilical artery Doppler at 28, 32, and 36 weeks. That's the correct answer. Fine? Fine with everyone?
Yes, ma'am.
Yes, ma'am.
Yes, ma'am.
So this is the last question. Who is going to take up?
Can I take it up, ma'am?
Yeah, sure.
29-year-old woman attends the antenatal clinic at 20 weeks of gestation. She is known to have hypertrophic cardiomyopathy. Echocardiography shows a left ventricular ejection fraction of 53%, which isn't bad. The woman is asymptomatic. Pulse is 76 per minute and BP is 123/73. Here, even though her left ventricular ejection fraction is 53%, still I would consider her as high risk only. So mother will be very high risk. Sorry. Mother high, ma'am, 25% and fetals low.
Yes.
Is it D, ma'am?
Yes.
Okay, why mother high and fetus low?
Because cardiomyopathy is known to affect the mother more than it is known to affect the fetus. At this point of time, there's not going to be any risk to the fetus per se. I feel that the mother's risk will be high, even though her left ventricular ejection fraction is 53%, which is actually supposed to be good. But still, the fact that she has hypertrophic cardiomyopathy will place her at a high risk.
Yes.
But HOCM, is it moderate or low risk?
Madam, HCM is an autosomal dominant.
HOCM is quite moderate or low number. It's not high.
It's moderate and low, ma'am.
So it is moderate and low because she is asymptomatic and her ejection fraction is good. When
Yes,
ejection fraction is less than 40%, then it becomes a high risk.
high risk.
Okay.
So this is basically at present a low risk mother, right? It is she is asymptomatic with good ejection fraction, so she is low risk mother. So mother is 5 to 10%. Now what about the fetus?
Fetus is of high risk.
Fetus will be
Low.
low only, ma'am.
Low risk.
What is the risk to fetus?
5 to
HOCM is autosomal dominant, so probably by high risk.
So autosomal dominant, so how the pattern will be?
I'm 50-50.
50-50 risk is there, but the thing is this is autosomal dominant, but what is different here is the way this is single gene disorder, right? There is only one gene which is affected. So as that gene expression varies a lot, a large variation is there as it percolates into the families, right? So not every time like it is transmitted, but it will not show every time, right? The variation and the expression of the gene has a variation. So according to that, this is a low risk here, right? Yes, penetration is variable. So this is low risk fetus because of variable penetration. If it penetrates to all the fetuses, then it will be 50% risk of having this disease. But because it is not there for all the babies, so therefore fetus is low risk here. So ideally, J should be the correct answer. Mother low risk and fetus also low risk. Right?
Okay, ma'am.
Okay. So J is the correct
Okay,
answer.
ma'am.
Right?
Okay, ma'am.
Yeah. So that was about all the EMQs. Those who have joined us today, if they want to continue with more EMQs, we have a 3-day EMQ workshop, 26, 27, 28. You can enroll for that if you are appearing for the July exam. Right? Fine. Everybody okay? Any questions?
Yes, ma'am.
Streams don't work unless we do. So we should keep on working till the last day.
Thank you so much, ma'am.
Thank you, ma'am.
Thank you,
Thank you,
ma'am.
ma'am.
Thank you.
Thank you.
Thank you, ma'am.
Thank you, ma'am.
Thank you. Thank you. Okay. Bye-bye. Good night. Bye.
Ma'am,
Thank you,
excuse me, ma'am.
Yes.
Ma'am, wonderful set of questions.